Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care because we're here to make your life easier.
Welcome to the Barbecues All-Round Primary Care Pod from Red Whale. The Primary Care Pod from Red Whale.
Whether it's doing your action plan with your gran,
Your action log with your dog,
or shouting, "I didn't know that" with your cat,
we're here for some discerning learning.
it's some Gravity CPD. So grab your preferred drink of choice, your trainers, or even a nice lolly. Here's what's bubbling up as we dive in search of our pearls for the second time this month. It's getting hot in here. At this time of year, on those hot afternoons in our consulting rooms, hands up if you think it can feel a bit, well, sweaty. Or perhaps don't put your hands up. Do you remember the antiperspirant advertising campaign from the late 80s, which was frankly sweat shaming? For people with hyperhidrosis, sweating is a year-round challenge that significantly impacts quality of life, relationships and work. Hyperhidrosis is thought to be underreported, possibly because people feel embarrassed. So how should we approach the consultation if people do raise concerns? Keep listening as we share all.
It's recently been the WHO World Hepatitis Day, so we thought we would reshare our article on Hepatitis C, which is a popular and impactful topic over the past 18 months on our update courses. We're doing this because more than 95% of people with hepatitis C can now be cured with a single course of safe, well-tolerated treatment. The WHO has set a global target to eliminate it by 2030. The UK is ahead of schedule, with England aiming to achieve elimination this year. That's 2025. We're going to zoom in on who we should test and how we should interpret the results.
And we start our episode this week with the third pearl of the month, and it's getting hot in here. And why is it that whenever I say that, the next line of a very famous song, which was The Sound of the Summer in 2002, gets into my head like a proper earworm, but I can't really say right here, right now, what the line is for copyright reasons.
I'm more concerned it's 2002. I feel really old. It's been going around in my head as well. Also, I feel I should point out that nobody has taken their clothes off.
Exactly. And I was going to ask you to rescue me, but you seem to have dug a hole a bit deeper there. So anyway, get us out of here quick.
So I remember seeing a chap with hyperhidrosis during my ST3 year and having literally no idea what to do with him. Kind of one of those things where you think, why are you coming to see me about this? Was it even a medical issue? That kind of thing. So I didn't quite know what to do. Was it something that I should just sort of reassure him about, or should I be referring him off to, I don't know, plastics or something? I'm not sure. Anyway, I remember going and asking my supervisor at the time, who also wasn't sure. So thankfully that was a few years back now. Okay. Steady on. And we've had a few really useful updated article and flowchart to help us with this. So that's what we're going to talk about today, isn't it?
Exactly. And when you were training, they weren't using leeches to treat this, were they? I can talk.
Yeah.
So I just thought I'd get in there. There we are, before you threw it back in my face.
Before you tell me how long it didn't take me to read.
Yeah. So how long? Well, it took me 4 minutes, 12 seconds. So how about you, Fee? How long did it take you to read?
I think it was 4 minutes as well. It's a lovely little pebble of learning, this one, isn't it?
Oh, I like that. Yeah, absolutely. So hyperhidrosis is a chronic condition involving overreactive sweat glands. Now, true prevalence is unknown because of underreporting and underdiagnosis. It can severely affect patients' quality of life and also their relationships and work too. The Pearl and associated article on Red Whale Knowledge is drawn from a BJGP clinical practice piece on the topic from 2024. The written pearl has a really useful flowchart which looks at the causes and categories of hyperhidrosis. So firstly, we need to consider, is it localised or generalised? And then we need to consider, is it primary or secondary? Localised hyperhidrosis is focal to one area, and generalised hyperhidrosis affects the whole body. Areas commonly affected by localised hyperhidrosis are the scalp, face, axillae, palms and soles of the feet. Localised hyperhidrosis can be primary or secondary, whereas generalised is usually secondary. So how do we know if it's primary or secondary, Fee?
Okay, so primary hyperhidrosis usually starts in childhood or in the teens, and it's believed to be caused by overactive hypothalamic thermoregulation. There's a family history in 30 to 50%, and it improves with age in some. And interestingly, it resolves during sleep. Localised secondary causes include chronic anxiety, stroke and brain tumour, spinal and peripheral nerve damage, and gustatory hyperhidrosis, which is triggered by eating or even thinking about food. Generalised secondary causes include obesity, diabetes, menopause, infections such as TB, HIV or malaria, malignancies such as lymphoma and carcinoid tumour. Endocrine secondary causes would include hypothyroidism and pheochromocytoma, and other secondary causes would include cardiovascular disease, respiratory failure, Parkinson's, and drugs such as antidepressants, steroids, opioids, illicit drugs, and alcohol.
Assessment and investigation are clearly very important because we don't want to miss any of those serious causes, and to this end, the history should include distribution of sweating, onset, timing and triggers, the psychosocial impact, drug history, family history and comorbidities, and associated symptoms such as weight loss and palpitations. If they're night sweats, then we should be particularly cautious about excluding infection and malignancy. On examination, we should look for signs of any underlying condition and signs of any complications such as intertrigo or bacterial skin infection. If a specific secondary cause or causes are suspected, then we should tailor investigations to these and refer as appropriate. If symptoms and signs are non-specific, then the BJGP article suggests the following investigations, which would be full blood count, UNEs for renal function, CRP, liver function tests, thyroid function tests, HbA1c, and also a chest x-ray as well.
Oh, well, there's a take action point right there, which might be practice changing for some of us, because I don't think I've been doing a chest x-ray for those presenting with hyperhidrosis. So that's a good one.
Mm-hmm.
Okay, so let's talk about management now. So the BJGP doesn't specify whether these management strategies are for primary or secondary hyperhidrosis, and we take this to mean that they could be used in either. The important thing to remember is that the treatment of secondary hyperhidrosis also involves addressing the underlying cause where possible. So let's start with some simple patient-initiated measures. So firstly, advising them to wear loose clothing made from natural fibres and advising leather shoes and an open design if possible. Mm-hmm. Then we can think about over-the-counter underarm antiperspirants. And have you seen that you can now buy whole-body antiperspirants, Nick?
I'm apparently aware of that.
I'm not sure how they differ from underarm ones, but anyway. You can also advise underarm pads and moisture-wicking socks and insoles.
Yes, and the other treatments are either prescribable in primary care or are secondary care, so that would be something like dermatology. So if we start with those prescribable in primary care, then we've got topical aluminium chloride antiperspirants and oral oxybutynin. So topical aluminium chloride antiperspirants, they can be used on either a PRN or a regular basis. They are up to 80% effective in mild to moderate hyperhidrosis. You need to apply them to clean, dry skin at night and wash them off in the morning. They can cause skin irritation, and which you would treat that with mild topical steroids if needed. Now, the BJGP recommends a 6-week trial of topical aluminium chloride antiperspirants before moving on to other measures. If we think now about oral oxybutynin, now this is not licensed for hyperhidrosis, so the usual patient discussions are needed, but it's endorsed by NICE in an evidence summary, and that's NICE 2017 ES10. The BJGP states that it can be initiated for hyperhidrosis in primary care, and it suggests a dose of 2.5 milligrams once a day and increase gradually to 5 milligrams BD as tolerated.
And of course, it may be that patients may have tried some of these things already before coming to see us. So I think it's helpful for us to know what dermatology can offer if we need to refer up. So they may be able to offer higher strength aluminium chloride preparations or oral treatments. You can have a look at the article for some of those, but may include things like beta blockers, glycopyrronium, calcium channel blockers. Also iontophoresis. So if you're not familiar with this term, then it involves passing an electric current through an iron-rich medium in which the affected part of the body is placed. Now, Nick, I've had patients who've accessed this themselves and then maybe come to see me and said, oh, it's still not working. So that's something to be aware of as well, isn't it?
Yeah, absolutely.
Dermatology also have access to things like Botox or surgical interventions or laser removal of sweat glands. And in very extreme cases, things like endoscopic thoracic sympathectomy.
Yeah.
I can't say it.
You can. You just did.
I can. And that involves cutting the sympathetic chain as it passes through the pleural cavity. So again, I think, extreme cases, but maybe it's helpful just to understand in context. And often people may come to us, in quite a kind of distressed state, thinking that there is nothing that can be offered. So, even if it's not us doing it ourselves, it's helpful to know that.
Yeah, and also the thing about the endoscopic thoracic sympathectomy is that what easy for me to say.
Easy for you to say.
but one of the complications with that is that you can get compensatory sweating, and so if you've been to all that trouble of having some kind of surgical procedure, you'd be a bit upset if suddenly you were sweating more somewhere else. So that's a big conversation. It's a big decision to make, I think.
Yeah, absolutely.
So here are your learning points for hyperhidrosis. It can be primary or secondary and localised or generalised. Generalised hyperhidrosis is usually secondary.
An important goal of assessment is to exclude serious underlying causes. This should usually include our examination, the bloods, and of course the important chest x-ray.
Initial management includes simple lifestyle measures and a 6-week trial of topical aluminium chloride antiperspirant. If these fail, then we can consider oral oxybutynin in primary care and or a dermatology referral. And if you're a Redwell Unlimited member, then you'll find a video by All About This next to 370 others that you can watch. Okay, and now it's time for the group hug part of the podcast where we help you through a difficult day at work. And thank you to everybody that has sent in their best intention stories so far. And if you've got a burning one to send in, then please do send it in. And the link is in the show notes, or you could also send it via text as well. So here we go. Dear Ali, Fiona and Nick, I read with interest your recent pearl about hyperhidrosis, and knowing that it would feature on the podcast the following month, I thought I'd share my overheating story with you. A little while ago, I was asked to present with some colleagues about a primary care project that I'd been working on at one of our protected learning afternoons. Now, I hate public speaking. And one of the reasons is that I hate getting hot and sweaty. It destroys my confidence just thinking that somebody might notice I've got sweaty armpits. So this time, I was going to do something about it. I got the idea from a TV presenter who posted on social media that the reason he'd appeared to have dry armpits on his broadcast to the nation was because he was wearing some kind of super absorbent pads in his underarm area. Suddenly, my plan took shape. I had no idea where I might get these underarm pads, but I thought outside the box. What could I wear under my arms that would be super absorbent? How about some sanitary liners that can be bought in any good supermarket or chemist? So that's exactly what I did. Now, if I was being clever and perhaps not so embarrassed, I would have asked a female friend or even my wife about what kind of sanitary liner to buy. But I didn't. Who knew that there were so many different types to choose from? So I panicked and I just bought the first one that I picked up off the shelf. What I hadn't noticed in my haste was that I'd inadvertently picked up some fragranced sanitary liners. So the day came for the big presentation, and about an hour before I popped to the loo, in inverted commas. In fact, what I was doing, I was locking myself in the cubicle and I was taping the sanitary liners to my armpits with surgical tape. Now, with the ultra-absorbent liners in place, I felt like I was the king of the world. At every opportunity, I was keen to show off how comfortable and confident I was by putting my hands behind my head to reveal my pristine and ultra-dry armpits. But the confidence didn't last very long. It was very hot in the venue that we were presenting in, and I became more and more aware that somebody was wearing a synthetic floral perfume, and it was super strong and not hugely pleasant, and it was giving me a splitting headache. And then I realised it was coming from me.
Oh.
The scent was pretty overpowering, and it kind of got you at the back of the throat, almost making you gag. The fragrant sanitary liners were very helpfully spreading their aroma far and wide, and the hotter I got, the stronger the smell became. This caused me to panic further. Somehow, we finished the presentation without me gagging, and it kind of went okay. It was only when I got home and took off the summer meadow fragrance pads that I felt really guilty, because I was worrying that perhaps my female co-presenters thought that the other one was the source of the flowery fragrance, and neither of them thought it was me. I mean, who would wear sanitary liners in their armpits? Not me. Well, never again. Well, certainly not any fragrance ones anyway. So thank you for letting me share my story, and thank you for making me laugh with your podcast. And that is from C. So thank you, C, for that story.
Only a clinician would do that. I mean, that is just the surgical tape. I mean, it's such a practical approach, isn't it? But,
exactly.
Oh, with
they
the
had the best
backfiring.
intentions. It didn't quite work
That's
okay
it.
for them. Bless them. Well, thank you
Wow.
for that story. And if you've got a best intention story, then please do send it in. Can you top that one? Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive. So Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery. But in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU indemnity, then you'll get a free Redwell course of your choice or a discount on Redwell Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Redwell GP Trainee Essentials to learn more. Have you got the calendar there?
Yes. So what's coming up in the calendar? Well, we're going into our period of writing new teaching material. So it's a very exciting time here at Redwell. The authoring team are finalising up their new and updated articles. They've been working really, really hard. So big shout out to them. We've just had our editorial meeting to work out all the most useful and practice changing topics that we're going to teach and include over the next rest of the year, really. And we'll be filming all of that new content over the next couple of months. So it's an exciting time. dates for your diaries and things to book on for. We've mentioned Hussein has got a live obesity course. So that's the first one, which is kicking off on Friday, the 26th of September. So do book your place onto that. We've got a menopause half-day course coming up 5th of September in the morning. So book your study leave and place. You can join Helen for that, but it's also on demand. So if you can't make this date, but you urgently need to get your menopause or HRT ducks in a row, then do pop that down. And we've also got our live GP update course on Saturday, the 27th of September. So lots going on, and hopefully far enough in advance to kind of get things sorted so that you can join us there. And if you're out and about over the next few weeks, then Hussein is doing a study day live for the East of England on the 19th of August. So if you're part of that, then do say hi to them, and remember to give our superhero nominations for the podcast.
Excellent. Thank you. And we've had a few voice messages, haven't we, Fee, which I think maybe suggests that you had a good time in Staffordshire.
Yes, I did. Went up with Hussein and we met loads of our colleagues up at Staffordshire Training Hub. It was a brilliant day. It was a face-to-face GP update course. And I managed to do a little recording myself through the voice notes, Nick, which I think came out okay.
Hello, Nick, and the Primary Care Pod team. It's Fiona here, and I'm with Hussein, and we're with the Staffordshire Training Hub, and we just want to say... Woohoo!
And you obviously inspired lots of people up there, because then after that, this came through.
Well, hello, Nick, Fiona, Ali, Hussein, everyone else at the wonderful Red Whale team. I happen to be a very silent but equally very ardent admirer of all of you. My journey with you guys started somewhere around 12 or slightly more months ago. So just post-pandemic, post-apocalypse, I started running, and I've been listening to the wonderful pods and pearls pretty much almost every day. To be honest with you, it's become my life so much so that even when I sit in a car and my mobile connects automatically with my children and my other half, one of your voices just suddenly comes out because it auto-connects. And then I get very dismayed looks by my family members. But just a massive shout out and a massive thank you to all of you, because honestly, it's like a breath of fresh air listening to actually health heroes, which you all are, which make our lives very easy and very clinically oriented. So I'm going to make a nomination for my health hero, and that is your team and the Red Whale team. And I think my reasons are very obvious. You've given me an impetus for just continuing to update my clinical acumen, my knowledge. My running has gotten better. And I think I've started to focus on things. You've given your podcast on lifestyle, dance, and everything much better. So thank you very much. Look after yourselves. And yes, thank you.
Oh my goodness, what a wonderful message. Thank you so much. You didn't tell us your name though, so I wonder if you could either send us another voice note, or you could send us a text message, or even email us. All the contact details are in the show notes. So it would be lovely to be able to say what your name is, but thank you so much. And you are the reason that we do the podcast, because we're here to try and make your lives easier and to get you through a difficult day at work.
So yeah, to everyone who's listening, it's really easy to send a voice note, and we love hearing from you. So let us know anything you like about the podcast, anything you'd like to see differently. Maybe even tell us things that you've managed to change on the ground, or some really great things that are happening where you work. We'd love to hear from you. Exactly. And also, if you've got a suggestion for the very top of the podcast where we say things about doing your action plan with your gran, if you've got an option to give us some answers for that, some further ones, then send those in as well. And now it's time for our fourth Pearl of the month, and Hepatitis C. Now, this one took me 21 minutes and 24 seconds to read. So it also took Fee about 19 minutes to read. So a good cuppa and perhaps 10 squats in the middle to keep your brain active. Now, the Pearl that we're going to discuss is based on a Lancet seminar from 2023 and the Hep Simulator GP Toolkit, and also the training module produced by the NHS Hepatitis C Elimination Programme.
Full references and links are in the written pearl. Now, we did cover this on the podcast a year ago, but we didn't release the free bite then. So if you prefer, then you can join Catherine to review this topic in a video bite, which is 13 minutes and 24 seconds long. Now, I'm going to put a link to that in the show notes, and you'll need to register for a free account to watch the bite. Now, over the past decade, the development of direct-acting antiviral treatments, that's DAAs, has revolutionised care in hepatitis C. It's now curable in more than 95% of people, usually with a single course of safe and well-tolerated oral treatment given for as little as 8 weeks. The use of these treatments in the UK alongside other successful strategies means that England is on track to eliminate the virus this year, which is 2025 if you're listening in the future. So what does this one mean for you, Fee?
Well, this is such an important topic, isn't it, Nick? But the thing that jumped out at me here was testing, and testing some more.
Yes.
Because we're trying to eliminate this virus, aren't we? But we're still trying to reach those who are most tricky to reach.
Yes, and if you want a reminder of the presentation and the natural course of hepatitis C, then we cover it fully in our previous podcast episode that was released on the 12th of July 2024, and it has the title, Does Spironolactone Have a Role in Acne Management? And it's also in the written pearl and also the free video bite. But this time we're going to focus on what we can do in primary care to help elimination happen. So we're going to look at when to test and how to interpret the results. Hepatitis C, or Hep C if you want to shorten it, is an RNA virus that can cause acute and chronic hepatitis, which left untreated can cause progressive liver disease and hepatocellular cancer. Transmission is bloodborne and there is currently no effective vaccine against it.
Now, for most people, over 70%, they don't get symptoms of acute infection and most develop chronic disease. Now, we can only find them if we think about transmission and if we think about risk factors. So we need to consider how it is usually transmitted and who's at risk. So let's look at the UK first, and then we can expand to the global situation. In the UK, the most important risk factor is injecting drug use. In 2021, it was estimated that just over half of people who inject drugs had ever had Hep C infection, and about 14% had active infection, although thankfully the numbers with active infection are rapidly falling, and we'll go into this a bit more later. Within the UK, having had certain medical procedures before the introduction of proper screening is also a risk factor. So if someone was given blood products before 1986, or a blood transfusion before 1991, or an organ transplant before 1992. Now, this remains a topical issue. I'm sure you've all seen the ongoing headlines regarding the infected blood scandal.
Sexual transmission is the second most important route of transmission in the UK, and it's commonest in men who have sex with men, with risk factors including anal sex without condoms, a high number of sexual partners, group sex and also HIV infection, ulcerative sexually transmitted infections, and exposure to menstrual blood during sex. Vertical transmission is also an important consideration, with about 5% of babies born to mothers with active Hep C infection acquiring the virus. Globally, unsafe healthcare practices such as reusing needles and unscreened blood transfusions are the major route of transmission in many low and middle income countries. This is particularly relevant to those of us who care for refugees and other immigrant populations, or for anybody who's had healthcare or other procedures abroad. So that's how you can get Hep C. When should we be testing for it, Fee?
Well, the bottom line is that we should have a low threshold to offer testing, and we should normalise testing as a routine part of healthcare to reduce transmission and enable that early diagnosis and treatment. So we think there are 3 scenarios in which we should consider testing. So firstly, in someone with abnormal LFTs, which is a fairly common occurrence in primary care, isn't it? Sure. Second is based on risk factors, and third is testing in other settings. So firstly, testing based on abnormal LFTs. So the take-home message is that we should screen everyone with raised transaminases, so raised ALT or AST for Hep C. And if you're a Redwell Knowledge member, then you can see our gems on abnormal liver function tests for more details there. And as an aside, if you're not a Redwell Knowledge member yet, then stay tuned for our 10% discount code at the end. But just to put a spanner in the works, normal LFTs do not exclude Hep C infection, so we should be mindful of that. So we're going to need to consider testing based on risk factors, and the most important groups for us to offer testing to are people who have ever injected drugs, and that includes gym drugs, so it's important to ask about those specifically. men who have sex with men, and people who were born in or who have had medical treatment or skin breaching procedures. So here we're thinking about cosmetics or tattoos in high prevalence countries. And the Written Pearl has a list of those high prevalence countries. The NICE guidance on Hep B and C testing from 2013, PH 43, tells us that after a one-off test in these groups, primary care should offer annual testing for Hep C if the person tests negative and remains at increased risk of infection. And that might be a change to practice for many of us. The Written Pearl has a table which shows the other groups who should be offered Hep C testing according to the PHE report, which is entitled Hepatitis C, Interventions for Patient Case Finding and Linkage to Care, and that was published in 2019. Nick and I will run through some important ones that we might not think of now, but you can read the full list in the article.
So if we start with sex related, then in addition to what we've already discussed, then we should offer testing to people who engage in chemsex and also the sexual partners of people with known Hep C infection and anybody involved in sex work.
Origin-related testing would see us offering testing to people born in a country with intermediate or high prevalence, and the PHE report says this includes Eastern Europe, Asia, Africa and Central America.
Social or environmental related testing would offer testing to homeless people, people who are in or have been in prison, young offenders, looked after children and young people, including those living in care homes. Close contacts of people with known Hep C infection, including household members, family and close friends, should also be offered testing because of the small risk of transmission via shared items such as razors and toothbrushes. Sophie, have you got some information on what testing we should do?
I do. Now, in primary care, there are two tests that we need to think about. So there's the Hep C antibody, and this tests whether a person has ever come into contact with the Hep C virus. And then there's the Hep C RNA, and this tests whether a person has active Hep C infection. Now, our usual first-line screening test for all the scenarios will be Hep C antibody testing. If someone believes they've been at risk of Hep C infection, it's important to consider the incubation period. If they initially test negative for Hep C antibody, we should retest it 3 and 6 months after the exposure. And as we just said earlier, anyone who remains at risk should be offered Hep C antibody testing every 12 months. Now, there are 3 scenarios in which we should request Hep C RNA, although I do want to say here that some of us may not even have access to this request separately, and our local lab may just add it on if needed, but if in doubt, speak to your lab, and there's a handy chart in the article. The first scenario in which we should request Hep C RNA is after a positive Hep C antibody test, and again, this may be done automatically by the lab. The second scenario is in an immunocompromised person, and that's because antibodies may not be produced in an active infection. And the third scenario is in someone who has previously cleared or been successfully treated for Hep C, who's at risk of reinfection. And this is interesting because antibodies aren't helpful here, as they'll be positive for life. So how would we interpret the results, Nick?
Well, there's a handy diagram with all the answers to this in the Written Pearl, but just to run through that now, here are the possible testing outcomes. So antibody negative and RNA negative, then this patient has never come into contact with the Hep C virus. Antibody positive and RNA positive, then this is active Hep C infection. Antibody positive and RNA negative, then this shows that there's been previous contact with Hep C, but they don't currently have the virus, so they've cleared it spontaneously or been treated successfully. And finally, antibody negative and RNA positive. Now, this is a rare finding, and this shows that there's active infection with Hep C virus, and either they haven't yet seroconverted or detectable antibodies are absent due to the person being immunocompromised.
And as Nick said, that is all in the article, and it's set out really nicely. So if you're a bit of a visual learner like me, it's good to know that you can just look that up.
Yes.
So if we find active Hep C, then we should inform the person and we should let them know treatment is available with a 95% chance of cure. And we can offer support as well through the Hepatitis C Trust. We should also refer urgently to hepatology, or you might be in an area that has a specific viral hepatitis pathway. So do use this if you have it. And if you're unsure, then maybe that's an action point to go and find out about. And we should also give harm reduction advice, for example, accessing needle exchange programs and also using things like condoms. If we're unsure about how to interpret the results, then we should discuss urgently with secondary care. And all of this is to get patients the treatment that they need. Everyone with active infection will be considered for treatment by hepatology. The goal is cure, which is a wonderful thing to be able to say, isn't it? And cure is defined as viral RNA being undetectable, and this is achievable, as we've said, in over 95% of people. And it's worth remembering that before direct-acting antivirals, or DAAs, the main treatment was interferon, which was given for up to a year by injection and caused severe side effects. So we must be mindful that when we're speaking to patients who may have experienced the old treatment, or maybe people close to them had that treatment, then we need to be clear that things are now extremely different.
Yes, they certainly are. And DAAs are now first line in almost everyone and can be used in either acute or chronic infection, regardless of the duration of infection or comorbidity. And there are DAA options that are effective against all genotypes of hepatitis C. They work by inhibiting viral replication and are given orally, usually as either an 8 or 12-week course. And the Lancet seminar series describes them as being exceptionally safe and well tolerated. Now, this next bit is really important for us in primary care, so remember this and think how you might flag it in the records. If you need to make any changes to the person's normal medication during their 8 to 12-week course of DAAs, then we should discuss this with hepatology due to the risk of interactions. There's an online interaction checker for these drugs, and there's a link in the resources in the written pearl, and I'll also put a link in the show notes.
And now the good news bit. I thought it was already good news, but even more good news. So the WHO has a global aim to eliminate hepatitis C by 2030. And NHS England aims to eliminate it 5 years ahead of that 2030 target, which is this year. England may be the first country in the world to reach hepatitis C elimination. Wouldn't that be a wonderful thing to say?
That'd be amazing.
Yeah, since the NHS Hepatitis C elimination programme began in 2015, the number of people living with active hepatitis C has fallen dramatically. Liver transplants have reduced by 52% and deaths from Hep C have reduced by 37%. That's in 10 years. And the number of people accessing treatment for Hep C has more than doubled.
And that loops all the way back to where we started, and we have a key role in primary care in the final stages of the programme to help identify those who are unaware of their Hep C infection by offering testing to everybody with raised transaminases and those in at-risk groups with ongoing testing if they remain at risk.
By coding risk factors and Hep C infection correctly, we can help identify people in need of screening or other outreach.
And we can encourage anyone with known Hep C who's been lost to follow-up or who has disengaged with treatment, perhaps in the era of poorly tolerated interferon therapy, to reconsider. Lastly, we can improve awareness by sharing information with colleagues and patients. Hep See You Later has resources that you can display in your practice.
The Hepatitis C elimination programme can support you with using a search tool as well called the Patient Search Identification Tool, or PSIT, which is now built into most clinical systems to search for those who may have undiagnosed or known Hep C and are in need of treatment. You can contact them via email, and also if you're interested in becoming a GP champion for Hep C, you can email them too, and we'll put those emails in the show notes.
And in addition, anybody in England can request a free self-sampled finger prick blood spot test kit for Hep C to use at home and return by post. You can order that online at hepctest.nhs.uk, and people with a negative result are informed via text, and those with a positive result are linked directly to their local viral hepatitis team. And just before we finish this pearl, a word about stigma. Stigma around Hep C is one of the major barriers to treatment. The Hep See You Later training tool has some suggestions as to how we can help tackle this stigma within healthcare. Much of this applies to other stigmatised conditions as well. So firstly, share knowledge with others. A key message for Hep C is that it's easily curable, and those who have been cured cannot transmit the virus.
We should inform people that they don't legally have to declare their Hep C status to anyone.
We need to use person-first language, so a person living with Hep C and not a Hep C carrier.
And we should link people to appropriate support networks. The support helps the person, and the visibility that the groups promote helps reduce stigma as a whole.
And we should make access to testing and treatment easy and non-judgmental. So we should think about how rigid pathways and protocols might deter people from engaging. So here are your learning points for hepatitis C. Thanks to DAAs, Hep C is now curable in more than 95% of people with a single short course of oral treatment.
We should have a low threshold for testing everyone with raised transaminases and everyone at risk, and continue to test every 12 months in those who remain at risk.
And we should refer all active infection to hepatology so that they can access DAAs. And finally, it's been a bumper month of 5 pearls, and we wanted to highlight to you our article that was shared as a pearl about mastitis.
Yeah, did you know that managing mastitis has changed? And we should now be looking at this as a spectrum of mastitis. And what we've done is we've summarised the updated guidance from the Academy of Breastfeeding in 2022 and other relevant sources focusing on mastitis in lactating women. So do have a read of the article. It took me just over 17 minutes. And we are grateful to GP colleagues Dr. Naomi Dow and Dr. Emma Cockerell for their expertise with regards to this.
Now, if you are hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell pod members. And so how do you become a member, I hear you ask? Well, if you're listening to us now, then you're part of our pod. And all you have to do is go to redwhale.co.uk, put Redwell Knowledge in your basket and enter the code RedwellPod, and that gives you your 10% off. And here's a small print. The discount code is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, RedwellPod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It should only take a few seconds of your time and we would really appreciate it. If you can spare a little more time, then please leave us a nice review too. Because of the way that algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcast platform.
And you can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want to see something about the podcast, then please use the hashtag RedwellPod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-well.co.uk. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Redwell Knowledge open on your desktop at work so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Bye.